it's really good to be here with you today. I don't have a watch. I have a Fitbit. And so I'm going to try to watch my Fitbit, so I had to pack on it to make it, show me what the time is. It's a little dangerous to give people who've been in academia for any time at all a podium, because we used to do, in my area in nursing, we would do 3-hour lectures, so I could do that, And so someone needs to tell me, because 30 minutes is not very long. And there's really, to me, there's an important story to tell, and I'm really wanting to share that with you today. One of the things that when Elizabeth and I sat together really a few months ago and talked about what we wanted to talk about today, and I really meant to start and tell you and share with you greetings from Governor Anatobi and the Chickasaw Nation. He's very proud of our relationship with OSU, proud to have a relationship with the Sovereign Center here, and so I'm very thankful to get to be able to be here representing the Chickasaw Nation and my tribe. And it's just kind of emotional to me. This is what sovereignty means to us. It's like, how do you even put that into 30 minutes? How do you put it into an hour or a week or a year? And what it means to us as far as healthcare. So that was what the goal was to be able to do, to share today. And I told Elizabeth, I felt like I wanted to, at noon you ought to get to hear a story instead of just a lecture. So I want to try to tell you the story of healthcare and how it's been a part of my life, and how being Chickasaw and healthcare is all just really woven together for me. And really, it's I was thinking about it as I was preparing for this lecture, such a very short time that we've really, so much has been accomplished when you really think about it. My father's great-grandfather, I'm going to make sure I'm going right. Okay, my father's great-grandfather was born in our homeland in Mississippi, in an area called Holly Springs. And when I think about that, and I think that my dad's been gone 10 years now, but if I could hold on to him and touch him, I would say you knew someone that came from our homeland. And how incredible that is, that it's such a short period of time just to reach back, just 2 generations. My dad remembers him sitting at their dinner table, and he had long braids. One of his cousins told me this story, that he would have a red ribbon braided in one braid and a green ribbon braided in the other braid, and he would do the prayer at the mealtime in our language, in Chickasaw. And just to think about that, and that where we are now with our health care, at that time all we really had was some promises from the federal government that had not really taken place yet. They hadn't been fulfilled. And we're really still, yet even today, in this healthcare environment that we're in, we're still working on that fulfillment. I mean, we've not ever been funded at the level that we need to be funded at. And so we're not there yet, but back then, they really didn't have anything. I mean, actually, the health was under the War Department, and that never made sense to me. I thought, you're the ones that brought the blankets that, that caused people to die, so how could our health care have been under the War Department? But it was, and so, golly, I've already been talking 5 minutes, I haven't started yet. So that was my warm-up, that was the beginning. But I think about my dad, and I think about his great-grandfather, Solomon Goforth, and to think that my dad actually knew him, and we have so many tribal members that can say that same thing, that I had a grandfather, an aunt, or somebody that, a family member that knew them, and that, could speak to those stories. And don't I wish I could go back and talk to him. And my dad, he didn't ask him questions. A 6-year-old doesn't do that. He remembers when he died, but you don't get those stories. So we don't really know very much. But I wanted to start off in looking at the historical, views, and how did we get here with our healthcare as we have it today. Well, it was those government-to-government negotiations, as our tribal people were, really forced. I mean, that's just the word that we have to use. That we were forced to give over lands. We were forced to give up where we lived and everything. And we have these treaties, treaties between not the states, but treaties between the United States government and tribes. And I think that's what's so important to remember, even with the environment that we're in right now, that the treaties between the United States is what is so important for us. And that's what we keep doing when we all travel to Washington, D.C. and talk about health care is that we remind them that it's a relationship between the United States government and the tribes of America, that as the things that we gave up, the reason that we have these responsibilities. We gave up our land and we gave up where we live. We gave up what we knew, and we had to, but we had a promise at that. I mean, there were so many things entitled or included with that promise. Teresa, can you all hear me? I told them that my dad, I didn't need a mic to project because my dad always said he turned his hearing aids off when I came around. So anyway, I can talk, and you know, you have to think. I'm trying to project to the back of the room. And this slide talks about that in 1803 that we were under the War Department, which was a very unusual position for us. 1921 was a very important act that was passed, and I know some of you might have heard of the Snyder Act. Snyder was on a committee that really gave him the opportunity to do some things that had a really impact on our lives. And my story, my dad was born that year in 1921. This part of the Snyder Act had to do with the preservation and the health care once again. So it was very important for that relationship that was beginning to be developed that would provide us and help to get us to where we are today. But you think about it, in 1921, my father was not a citizen of the United States. The act that was passed in 1924, 3 years later, was actually the one that gave my dad citizenship. So that's really interesting to me just to think about it. So in the 1830s, you know, we were getting ready to give up our homeland, coming to Oklahoma, and some of these acts really were very, very important. Somebody recently said, we were talking about, what if the Indian Healthcare Improvement Act does not get preserved? It's embedded in the Affordable Care Act right now. And what if that what if it was not any longer? What would happen? And somebody made the comment, well, we would have to rely back on what happened with the Snyder Act. So Snyder, what he did was, he was from New York, and it was very important for us. It was under the President Harding, and I don't know if you've ever read very much. I've read a little bit about him very recently, and they were saying he was not a very popular president. He only lived 2 years. He died in office, but this was important. So I'm thankful for that he did. The healthcare duties were transferred to the Department of the Interior and later renamed the Bureau of Indian Affairs in 49 and 55. Now, I was 1 year old in 55, and so this is important to me. It was, we were put under the Department of Health and Human Services. The money still goes through the Department of Interior, but we get the money through DHHS, and so that's kind of important and kind of interesting to me to look at. I was going to read to you, to me, is pretty neat what it says about the Snyder Act. Being enacted by the Senate and House of Representatives of the United States of America in Congress assembled, that the Bureau of Indian Affairs, under the supervision of the Secretary of the Interior, shall direct, supervise, and expend such monies as Congress may from time to time. I thought, ooh, that was a significant wording, because right now our funding is kind of almost at we're not getting very much of an increase. As a matter of fact, we don't have anything at all right now. But anyway, money from time to time appropriated for the benefit, care, and assistance of Indians throughout the United States for the following purposes. And it's those things that are listed on your screen. It had to do with our education, our health, our housing, had to do with our court systems, our police systems, all of those, suppression of trafficking of intoxicating liquors. And again, this was under President Harding, the 29th President of the United States. So we have a lot to be thankful for various presidents, and he was one of them. So I'm going to skip forward a few years and go to another really important act that I know that some of you have heard about, and that's the Indian Self-Determination and Education Assistance Act, Public Law 93. I should have written it down because my mind, I know it, we all say it. It's the only one that I name all the numbers on, and for standing in front of you, it's not hitting my mind, but it will. And this one recognized the responsibility of Congress for self-determination of Indian involved in participation in direction of education and service programs, and health was included in this. And the importance of 93-638, I knew that it would come around here on the, I think it's like a record to me. I know it's going to come around in here a minute. You remember the little piece of lint that would go around? I think the lint, it's coming. I know it, 93-638. That really has so much to do with our tribal sovereignty. And when tribes had that opportunity to make decisions about do they want to, you know, can we do things for ourselves? And I think about even back in my own family history that our tribal members, our parents, our fathers, and our mothers were told that they really couldn't, you know. And so the relationships between the federal government and tribal people became so, it's almost dependent. As a matter of fact, the wording of Chief Justice John Marshall in a law, public law, was that we were called dependent Indian nations. And once when I went to the Library of Congress, I remember looking around and looking at all the beautiful, the tiles. I look up at the ceiling and there is that, you know, Chief Justice John Marshall's name on one of those tiles. Have any of you seen those? I mean, there are different names, and I look up and I think, you know, you had that which was really going to be a negative actually became a positive because it helped us in that building and the relationship between tribal people and the federal government. So the Indian Self-Determination Act was Indian Self-Determination Education Assistance Act was really very significant for us. It had there's been a lot of times that it's been amended, and it was one of those times was under President Ford, but it just really helped to seal in, and I think help us as nations to really utilize and operationalize what tribal sovereignty really means. And if you've ever spent very much time talking with Governor Anatobi, I say he puts on his tribal sovereignty glasses when he looks at anything. And he looks at it and he'll ask things, and sometimes I'll think, I never would have thought of that. You know, I never would have thought of that as being a potential threat. But anything that he sees as a possible threat to us, he takes it very seriously. And so, I mean, and I really admire him so greatly for that. Another act, I want to make sure we're on the same page. I never did turn it, did I? The Indian Healthcare Improvement Act, which occurred in 1976, is another one that was very important for tribal people, and it's the one that I mentioned right now that is in the Affordable Care Act that we are striving very hard to keep within that act, because it really does, once again, it kind of seals that relationship with the federal government and tribes for the continuation of Indian health care, Indian services, the facilities that have been built, the access to health services, the just about everything that we do in healthcare really to me is out of this act. So it's something that's very important. I remember whenever I was elected to the tribal legislature in 1994 that I began hearing, I didn't know anything about it till that time. I'm teaching nursing school, and that was what I thought I was going to do with the rest of my life. And somebody asked me one time, have you ever thought about running for tribal legislature? And that was the week that you signed up to do that. And that was on Monday. I said, well, I haven't, but by Friday I had, and I did. And so I won. And the very first thing I did, the very first official thing I did as a tribal legislator, I was elected to office, took the oath of office October 1, 1994. And that very day, Governor Anatobi said it was at night. I don't remember being there at night. But anyway, we were ceremonially handed the keys of the Carl Albert Indian Health Facility, which had been there since 1980. I'd been taking students there for 14 years. And again, I was telling Elizabeth, to me, you know, my whole life is woven in healthcare and in the Chickasaw Nation. I mean, that's just, when my son and I were talking about it, I was telling him last night, for 22 years, I've not worked in a setting that I'm not getting to work with Chickasaws every single day. You know, as we were talking last night, and he was asking me, you know, I need to know more about our history, and we were just thinking about that. But in 1994, because of the Public Law 93-638, we entered into a compact with Indian Health Service, and the Chickasaw Nation decided or they decided quite some time before that, but that we would run our own health care. I know that the months and the years prior to that time, that members of the Chickasaw Nation were going out to the Chickasaw Nation, going out to different, our tribal members and asking them, you know, what do you think about it? And we wanted to get the support of the Chickasaw people. And I'm told this, Governor Anatubby tells me this story, and Linda Briggs, who is a current legislator right now, and she was one of those individuals that went out to Chickasaw people and said, you know, what do you think about us running our own healthcare system? And there was some fear in that. The Indian Health Service had done it since 1980. I was there in June the 14th, 1980, whenever the facility was open and dedicated. My dad and I were there. He was the second employee for the Carl Albert Indian Health Facility, Carl Albert Indian Hospital, we used to say. And so I'd been there since day one. I didn't ever know that they were going around and asking those questions. I wasn't very involved in tribal politics. My first really introduction to tribal politics was when you probably know that Governor James was appointed as our governor in 1963 by John F. Kennedy. And then in the early 70s, I think it was in 72, I'm driving a green Volkswagen, and I'm graduating from high school, and my dad ran for governor against Governor James. He didn't win, obviously. He got 50 votes, but on the television it said 500, so we were all so excited. We knew it was only 50, but it made a better showing, you know. That was kind of my first real introduction very much into tribal politics. I was raised in the Choctaw Nation. I know I'm going to have to keep going, because if I'm not, we're not going to get the whole story told. I want to tell you the things that have happened in this short period of time, from the time that tribes really started taking over our own health care into where we are today. With the Indian Health Care Improvement Act and Public Law 93-638, there were some advantages and disadvantages that people thought about. The tribal motivation was, it was time for us. I mean, I think we could have probably done it all along, but we were grown up enough, it was time enough for tribes to take over their own destiny, to do things, you know, for themselves. We needed to do that and not always have the federal government to do that. And so tribes had a very great motivation to get away from some of the paternalism that took place between the federal government and tribes. And you know that we're all in different places. Not all tribes have even made that move, but our tribe did. Our tribe did decide to do that under the leadership of Governor James, and also then Lieutenant, I can't hardly say that, I want to say Lieutenant Governor Anatubby, but anyway, Lieutenant Governor, and that's what he was. That's when I met him, he was Lieutenant Governor. But you know, whenever he did that in 1994, he was our governor. Had been that way since 1987. But there was a lot of motivation for tribes to do that, improve self-esteem, a lot of things. I think that we were ready. Some of the disadvantages, and this goes back to what happened whenever Linda Briggs and Frank Johnson was going around. If some of y'all may know Frank Johnson, who was a tribal legislator, Lisa Johnson Billy's father. He was going around also asking those questions. And these were some of the disadvantages. I mean, there was a lot of fear. There's a lot of good in Indian Health Service running a tribal health program for you. They had been doing it for years, since the 50s. And so now here 35 years later, we think that we want to do it for ourselves. And I will say this, and I usually say this at the beginning when I'm talking about us and I'm talking about Indian Health Service, is that our relationship is great. We have a very strong relationship with Admiral Meeks, whom most of you all know as Chickasaw, but who is over the Oklahoma area. And even if with others who have been in there, Dr. Grimm, others who have been in that same position, we have a very strong relationship. But I think that we made the very right decision to do what we did as the Chickasaw Nation. But there were disadvantages, you know. Fear would be something had happened. And the other thing is just knowing that, you know, we hadn't done this before. There were tribal people. Governor said that whenever when we did this, that he had to go get resolutions from the other tribes as well as the Chickasaw Nation, and it was easier to get the resolutions from the other tribes than it was from us. There was just a lot of fear related to what was going on. Now I'm going to skip this next slide. I'm having the feeling because I really did get, I'm going to look at my watch. Elizabeth, you might give me a when do you have 5 minutes. I don't remember when I'm stopping.
I'll give you a 10-minute warning and then a 5-minute warning.
Okay. I probably won't look at you when you do it, but anyway. Remind me to do that. But I want to talk a little bit, and we're going to go back some. Any questions on what I've said so far? We're going to go back a little bit because when Governor Anatobi, and someone was saying, I think Danny was telling this, is that when we sit at his feet, when we sit and talk with him, Governor Anatobi always tells some history. And the history that he tells as a little boy living in Tishomingo, Oklahoma, he remembers when there was a health clinic, like on Main Street, close to a bank. He remembers when there was a trailer for dental care that would be moved to various places, and it would be only for children. And so he remembers that if you had something really serious, you're going to have to really travel very far to the west, go to Lawton, or you're going to have to go far to the east. We just didn't have very much in the central part of Oklahoma. And so it became a dream of Governor James at the time for us to have that. And so that would be the goal. That clinic that is showing to you right now is one that we built some years later. In the clinic now, we've now built a brand new one through a joint venture that's right to the east of that clinic, and this one has been remodeled to another, for another facility. But that's where we started. We started in Tishomingo. We call this the Indian Health Service years, 1973, and this is some of our history. The Oklahoma City Board comprised of representatives from the 35 federally recognized tribes voted to designate Ada, Oklahoma as a site for the long-awaited Indian Hospital. Now, that vote, there really was a real push to get that in Seminole, for it to be in, not Seminole, but be in Shawnee and not Ada. And so, with the help of Governor James and Representative Carl Albert, who the facility was later named after, and working with Congress, we were able to get that in Ada, and that's been something really important for all of us. The tribes that were involved, I'm going to read these to you because I can't ever remember every one of them, would be the Creeks, Seminoles, Citizen Potawatomi, Absentee Shawnee, Kickapoo, Iowa, Second Fox, Choctaws, and obviously the Chickasaws. And once again, Governor said it was pretty easy to get all the other tribes to be willing to do that. And for the Chickasaw Nation, we agreed, and it was actually voted on before I ever became a legislator. So that must have happened in probably, I would say in 1993 would be my guess, maybe 92 or 90, sometime before. If you look at this shows you the map of the Chickasaw Nation. It also shows you the area of what we call the Ada Service Unit. And so our counties became the Ada Service Unit. The kind of interesting thing on that one is that the Chickasaw Nation and the Ada Service Unit are different land bases or footprints. So there are parts of the Chickasaw Nation that are in the Lawton Service Unit and parts that are in the Choctaw Nation Service Unit. It makes it a little bit difficult whenever you're talking about contract health dollars and you're talking about referrals. It really makes it difficult when you're talking about your citizens, and if you have somebody that lives in Duncan, Oklahoma, and they come to the Chickasaw Nation and they need to have a referral made out, and the referral has to go through Lawton. And that's really confusing. A little bit difficult for our people, but we work on it hard, and we try to make sure that we help take care of everybody, whether they're within the service unit or outside of the service unit. We're in the IHS years. If you'll notice, the gentleman on your left is Mr. Neil McCaleb. Has he been here before and spoken to you? And then a few times. And then Governor James, and that was on a groundbreaking day in 1978, and very important day for us. Mr. McCaleb was actually our architect. And when they remodeled, it's now called the Carl Albert Service Center. The Carl Albert Service Center was so well constructed the concrete and everything that was there is that we were able to use that facility. There was a lot of gutting, a lot of things that were taken out, but it was really well put together, and we were able to utilize this. Here's the ribbon cutting, and as you can see, Governor James is in that again. Very important day for us. And if you talk about, you know, what does that mean for us as far as our health care? Well, I have received my health care under the Chickasaw Nation from 1982 on. That's the only place, unless I get referred out. There have been a couple of times when my children were little, I said, I'm not going to do this anymore. I'm going to go out and try private. I would go out maybe 1 or 2 times, and then I came back. It's just where my family is gone, and that's what we believe in. I support it fully. The dedication of our facility was important. Anyone recognize Governor Anatobi? A younger Governor Anatobi. Contracting for the management of health services first started in a 638 contract. Now, you know, contracts and compacts are different. Compact is what we did in 1994 when we actually took over the care. The contracts were the things that we did parts of it, and Governor Anatobi tells that story. We contracted for our CHRs. CHRs are a really old program of what we call community health representatives, and they go out, and they still to this day go out, and their funding is really coming under siege right now, so we're hoping to have the continued funding for CHRs. But they go out and see our people, you know, go to their homes. Probably 95% of the time they're Chickasaw, and so, you know, they know the elders, they know everybody. They go out and see them and make sure that people are okay, and I think is a very important part of our healthcare preservation. Another thing that we contracted for is, I don't know if any of y'all remember that the Carl Albert Hospital had the solar units on the top. And I remember the gentleman from Colgate that used to keep those things running. I don't even know when they stopped. I just, you know, when I got there in 2009, I didn't realize that they didn't work anymore. But they provided a great deal of our heating and air conditioning. But that was one of the things that we contracted for, was to keep those power units clean. And the other thing that we contracted for was public health nursing. So as you can see, even in this period of time in the 80s, I think we're getting ourselves ready. We're, you know, flexing those sovereignty muscles. You know, let's see what we can do. Let's see some things that we can do. So those are some that I really appreciate Governor's history and sharing those with us. Now, this is interesting to me. The facility, and we're going to get to at the very end, I'm going to show you how many people that we're taking care of right now. But the facility for the Carl Albert facility was built for 35,000 patient visits to be seen annually. We were supposed to have 275, and at that time when it was open, there were 217 positions. They came from all over the United States. They were, for the most part, Commissioned Corps officers, and we had them they would really sort of come and go. You know, you would have someone that would come in and do maybe a year of their service or 2 years. It would be kind of unusual to have one be there for a really long time. I don't know if any of y'all know Dr. John Garber, and he's an optometrist, and he was an unusual one in a lot of ways. But anyway, he was unusual because he's funny. He's just funny, or something anyway. But anyway, Dr. Garber stayed there for many, many, many years as a Commissioned Corps officer. But a lot of the providers kind of came and went. And this again tells you the tribes that we were serving. And of course, we serve tribes, all tribes. These are the ones that were in the agreement with us for the Carl Albert facility. But we have tribes from all over the United States. We have people that fly from Washington, D.C. They drive from Houston. They drive from, I saw a patient not too long ago. I work in the women's clinic, and I had a patient come in, and I said, you know, where are you from? And she said, I'm from Houston. And she had driven up the day before. I saw another one like a few weeks later, and she was, she lives in D.C., and when she flies home like at Christmas or Thanksgiving, that's when she gets her appointments. And so it's pretty interesting. People come from all over. Well, things are moving, you know, things are growing. Other things that we've done, this tells you about some of the things that we've done, and this talks about some of our food and nutrition. But the next thing we had was clinics in Ardmore. In '84 marked the opening of the food distribution program. These are so important for the health of our people. The Ardmore Clinic opened in '85, Ada Nutrition Center in '86. We have WIC programs all over the Chickasaw Nation that are adding to the lives of our tribal members, all tribes actually. And then '94 again, the 638 Compact, which I told you about that. And the significance of that. I will never forget that. I will never forget sitting and watching Governor Anatubby receive those keys. And now what I want to focus on toward the end of our visit here today is to talk to you, and I know Elizabeth wanted us to talk about, you know, what are we doing? How has health improved? So you think about in 37 when we moved here under the War Department, there really was very little, if any, health care. It started really growing in the 50s, and by the time we reached this time in 1994 when we compacted, this is an old picture of the Carl Albert Service Unit, and now that's whenever we didn't, that's a little, I think, prior to the compact. This one shows you, you always know of a Chickasaw facility because Governor Anatubby likes green stuff and flowers, and so we always have a lot of flowers and a lot of beauty, and so this is after we had taken over the facility in 1994. Kind of looking at the next 10 years, what we have done is, this is Governor's philosophy is, whatever we can bring in-house we should, because for the things that we need that we don't have that are there, we have to send people out. And that's where we used to talk about it, contract support cost or contract support care. We call it now purchase and referred care, and so if you can't receive your care there, then we're going to have to send you out. And so he says, and I agree, it makes more sense to bring that care in. And that's a part of our exercising of our sovereignty. We get to make those decisions. And I know that Indian Health Service works to do that now, but we really do, and we have for a long period of time. We've put money into wellness centers, and I know that you know, you appreciate those, and that it's something that we're using to try to improve the health of our tribal members. We opened a comprehensive diabetic care center, and that was actually at Carl Albert when we built that, and that was after the compact. It was, I remember the days prior to the compact. It was a room, and it was about as wide, like from here to there, and it was cubicled off, and so that the 4 people who were taking care of everybody who had diabetes were in this room with these little cubicles. Well, after the compact, I remember this one as a tribal legislator, we built the new diabetic center. And of course, now we have a whole area for that at the medical center also for that. Our patients can come in there, they see a nutritionist, they can have, we can do food demonstrations, they can get their dental hygiene or their teeth cleaning done there, all in that same place. And Dr. Curtis Harris is our endocrinologist, takes care of them. We have a nurse practitioner. I mean, that's a lot of change from the little room I saw. I remember looking in it, and some of those people are still working with us. Bobby Sankey, who works in he's really more in epidemiology and our Department of Public Health and Research. But I remember seeing him in there, and we worked together for years because diabetes was always a passion of mine. But I mean, you think about that change, and that's, again, to me, that talks about sovereignty. And you want me to say, I know I've said it 30 times now, is it too much? But it's cause we're doing the things that Governor Anatubby had as a vision. So a lot of change has taken place. We built a clinic in Purcell in 2004. A goal of Governor Anatubby's was that our patients would not have to drive more than 35 miles to get to health care. Now, the only area where we haven't quite reached that goal is on the western side of the Chickasaw Nation, and it gets into some of those, a little bit of the issues of you live in the Chickasaw Nation, but you're in the Lawton Service Unit. So to try to help offset that, in about the last 6 months, we bought a mobile medical unit, and we're working right now to get that thing ramped up so we can do some services. You can't do everything out of a mobile medical unit, but you can do a lot, and so that's one of our goals. So this is one of the clinics in 2004. And what we're doing now that's not even in that presentation is that we were able to double the footprint size of that clinic, and that part will be opened up and expanded here in just the next few weeks, and so that's really exciting. In Purcell, they've never had the expansion of dental care. They've never had physical therapy. They've never had imaging. Like if you were in Purcell and you needed imaging, you either drive to Ada or maybe go to a clinic there or a hospital there in Purcell that's, has a contract with us and is willing to do that. But they're going to have that right there in their own facility. And again, to me, it's really a part of, a tribe doing, this is what we want to do. 15 years after the compact. And I really did get to live through all of this. I mean, I took students to Carl Albert for 14 years prior to, or something like that, 10 years prior to becoming a legislator, and took them there for 24 years. As Elizabeth was saying, I taught for 24 years. But the expansion of services, I know that you can see all of this, but the goal is always to be, what more can we do? That's kind of a theme of our leader, is that I learned this, it took me a while to figure it out. I was wanting to say, good job, but I would go in and he would say, what else can you do? What more can we do? So I've learned that, so we're always thinking, what more can we do? I was in the legislature. I remember when he gave the charge to the nation to look at planning for the new medical center, and I'm hoping that I have some pictures of that I can share with you. This is, again, some of those exercise facilities that I was telling you about. We have those now. There's now one in Purcell that's been added that's not even in this slide. From 2010, I joined the nation as an employee in 2010. I didn't run for legislator that year, and I retired from teaching. And actually in 2009, 2010 is when we moved to the new medical center. And that was a great day for the Chickasaw Nation. The footprint was, we went from, I know that the Carl Albert would actually fit in our outpatient clinics right now. We have 370,000 square feet. The facility that was built to see 35,000 people a year when we left in 2009 was seeing 300 to 400,000 a year. So we had outgrown. We had really totally outgrown. We've done a lot of expansion. I know you're seeing this on the slide. This is the footprint. How many of you haven't gotten to come to Ada to see the hospital? Everybody? Okay, a couple of you. This is the architectural rendering of it. And the outpatient, let's see, he told me there's so the outpatient clinic is right here in this area, and that's what Carl Albert fits into, literally. That's the size difference. And so for me, as a tribe, we joined in a joint venture with Indian Health Service, and this was one of the greatest exercises of our sovereignty. We were the first tribal organization to to get a joint venture for a hospital. There are clinics all over, everywhere. Thank you, I saw that. There are clinics all over the United States, and we actually have 2 joint venture clinics now. But joint venture means that Indian Health Service will provide you the staffing, so the additional staffing that we needed and identified at that time, they provide that funding. But the tribe has to pay for and has to build the facility. This again took a vote of the legislature. I was in the legislature at that time when I voted for it. I didn't know I was voting for my new job, but I'm glad I voted yes. I have to tell you, there's some times I voted no. I had this thing about, how can I, as a healthcare provider, vote for a smoke shop? I just can't. So I remember doing that. I voted no when they said, well, we build a new smoke shop somewhere. I said no. And we don't rely on those very much and have them even less. The other thing I didn't really enjoy was, took me forever before I would say the word casino, because I don't like that either. So I don't do gaming, and so I thought I'd just call them a gaming facility. And someone finally corrected, you just go ahead and say it. It's actually a casino. So now I can say that. But I had a hard time voting for those. And I was actually in the nation when, in '94, the only thing we really had was a bingo facilities. And that was where extra revenue came from. And so it was a little difficult for me, you know, but I'm glad I did, because it helped us. I mean, we actually got bonds for the facility, and I can tell you now that the hospital is almost completely paid for, years and years and years in advance, with a savings of millions of dollars. So that's a great thing. I will do this. I will share with this to you. Most people don't know this. And I remember when we told somebody this one time, it was Indian Health Service. They were down visiting, and I said that our budget for the medical center, there is no, it's like I say, it's sort of like the placenta. The blood barrier doesn't work here. You know, it totally stops it. We get no money from the commerce side of the tribe. Our budget is, you know, what we get from Indian Health Service and with third-party reimbursement, which is really, again, it's a part of tribal sovereignty. I feel like my story, I hope you're following me. I mean, I feel like I'm tangling things just a little bit. But I remember in the Carl Albert days, my dad and I could not understand this. My father was a hospital administrator. He did x-ray and lab at his little hospital that he ran in Atoka. We worked together at Carl Albert. We could not understand why, when we came to the healthcare facility and they took care of our health, we never got any bill through our insurance. It just never did happen. Well, now almost a half of our budget, and Marty says in 2 years more than half of our budget will come from what we're doing with third party, with Medicaid, Medicare, and private insurance collections. And that's real important. Indian Health Service sees the importance of that, but they don't do it to the degree that we do. So Elizabeth said I have 5 minutes. This is the groundbreaking day. I was a legislator here. Ribbon cutting day, I was an employee, so that was kind of wild for me. But it's been very important. Other tribes are following in our footsteps. We were not the first first tribe to do for a compact. We were among the first 10, but we were the first to get a joint venture. Some of the things that we have done, you can look at all of those. Those are things that we have added to our services that we were not doing prior to the compact years. Our patients can come to our facility. I had a patient that I saw just a week ago who came in and said, I have this mass in my breast, and I sent her to my mammography. They did a needle ultrasound guided biopsy that very day, just when she came there. What would have happened years ago when the mammogram bus comes along, we'll get you a mammogram then, or do someplace, go someplace else. And then you're going to have to wait, and we'll get you out for a biopsy at some time. So you can see the difference that those things make. And that's just one example of a person that I got to see. I mean, it meant a lot to me. It really did, to be able to see what differences that we have made. Other things that we have added, I know the retina clinic, Dr. Franson comes down from Oklahoma City. We have an agreement with Dean McGee. When I first came to Carl Albert in 2009, he was coming to Ada only. Now he goes out to some of the clinics. And as far as diabetic blindness, we hardly see that anymore. It used to be that you would find out people were diabetic when I started in the 80s, when they came in and they were blind. And that would be part of the diagnosis, that they have diabetic retinopathy and they can no longer see. So imagine the differences. Blindness from diabetes is now very, very unusual. So these are a lot of the services that we've added. We did a joint venture. This is our Ardmore clinic, and we have a brand new clinic there. And also just some, kind of neat pictures related to that groundbreaking. But all of those services that we add to Carl Albert, prior to, I'm going to say like 3 years ago, we didn't ever have pediatricians in any of those clinics. We now have a pediatrician in Ardmore. We're going to have one in Purcell and one in Tishomingo. And so just, you can imagine the difference that that's making in the lives of children. And back in whenever Governor Anatomy was talking about in the Tishomingo clinic days, it was only the children that would even get the dental care, not adults, just the children. And now everybody, anybody can get that dental care. We have, again, everything that we try to do in Ada, you can't do it all. We don't have MRI or CT in those clinics, but we have it in Ada. We did not have that. I remember in the Carl Albert days, and you probably get tired of hearing this, but you know, if you had a trauma, and I remember in one of my trainings, the radiologist said, this child had a brain injury from trauma. Well, we would be having to look at that through x-ray, and the difference of that between that and CT, it's just night and day. I mean, you can see that this kid had a traumatic bleed, and he said with x-ray you can really hardly catch that. So that's a lot of difference, a lot of lives that are actually saved. And this is a Tishomingo clinic, which quite honestly, we probably shouldn't have spent all the money on the cultural part of it. I mean, it just looks so beautiful. It really speaks highly of our culture. But I think people like it, you know. Maybe we should have put the money, maybe we should have cut back on that. But we didn't, so anyway. So we're there, they like it, and it's beautiful. If you haven't ever gotten to see it, it is so beautiful. And we actually had our elders get involved in helping us, you know, pick up some of the design of that. Now, we're going to, if you have problems with seeing things move fast, the thing that's different about, this is what I wanted to show you on the numbers. So, this is 2009, and if you look at the numbers of citizens, this is one of the things that Elizabeth asked me to show you, is the numbers of those who are in our user population, or our user pop. And so this is the numbers that we have counted in our user pop. That doesn't mean that's all we see. We see a lot more than that. But you can, it's sort of a build it and they will come. And then we just wanted to show you this one, and this is talking about the ambulatory visits. Remember, it was built in Carl Albert for about that much, about 35,000. So here's 100, so it's way back here. When we left in 2009, 448,000. And if you look at our numbers for 2016, at 827 plus thousand. So that's tribal sovereignty and healthcare and my life altogether. So thank you all for the opportunity, and